In my last video, we discussed how autoimmune atrophic gastritis can be an autoimmune root cause behind low stomach acid, and low stomach acid can manifest as symptoms of indigestion, post-meal fullness or early satiety, bloating, GERD, delayed stomach emptying, and possibly other symptoms including abdominal pain, abdominal pressure, and constipation. And we discussed how this is very common in people with iron deficiency that is not responsive to supplementation, B12 deficiency, and people with an autoimmune disease. And this is a frequently undiagnosed or misdiagnosed condition. And I hypothesize, for one, that a lot of people with autoimmune atrophic gastritis are incorrectly told that they have SIBO, and they chase that goose instead of getting to the real root cause of what's making them feel bad. So in today's video, part 2 of a 3-part series, we are going to be discussing the initial diagnostic workup so that you can try to rule this in or rule this out with your medical team. Now, I say step 1 because there is a step 2. I'm going to ask you right now, oh viewer of YouTube, please don't order the blood work, get something positive, and then diagnose yourself from your couch or your living room. You really do need to work with your provider and go and get your GI doctor on board and get a scope and try to definitively rule this in or rule this out. A, so that you know that you're chasing the correct clinical target, but also because this clinical condition is known to increase your risk for certain types of gastric cancer. And you're going to need to have some sort of process in place with your GI doctor to make sure that they are scoping you and checking on you regularly to catch that early if it does, heaven forbid, happen. So again, this is going to focus on something in my wheelhouse, which is ordering and interpreting blood work. But the part 2 would be to work with your GI doctor and get a scope and try to once and for all rule this in or rule this out. Now, that being said, the blood work that we could do as the initial diagnostic workup for this condition can be broken up into 3 separate categories, 2 of which are talked a little bit more about in research. So we can focus on the autoimmune markers because, like any other autoimmune condition, there is an autoantibody that can be detected in blood, and we can deduce whether or not you have the condition based on that to some degree. There are also nutrient-related markers, namely vitamin B12 and iron deficiency markers, which I'm going to discuss. And then last but not least, there are blood markers of gastric corpus atrophy, and that would be an indicator of low stomach acid or loss of the glandular function of the stomach. So we're going to start over here with the autoimmune markers, and we're going to move our way across the board. But let's start with the 2 antibodies right out the gate that are the hallmark of the autoimmune process in autoimmune atrophic gastritis, aka AAG for short, for the purposes of this video. So number 1, there is anti-parietal cell antibodies. Now, this is going to be said a little bit different from lab to lab. When I was looking at Quest and LabCorp, one of them just says parietal cell antibody, the other one says anti-parietal cell. It's the same thing. It's an antibody against the parietal cells that make stomach acid in your stomach. And that is so there's number 1. Parietal cell antibodies or anti-parietal cell antibodies will be the first one. Now, this is the antibody that presents first in the condition. So you're going to see this earlier in the onset of the disease, as opposed to the other antibody, which we're going to talk about in a second. And it is present in somewhere between 60 and 90% of autoimmune atrophic gastritis patients. So it's there. It's not a slam dunk. You are going to miss some people if you just use this, but it is there in the majority of people with this condition. It has a high negative predictive value, which means if you get a negative result from this, there's a pretty good likelihood that you do not have this condition. But if you use the LabCorp or the Quest ranges, which oftentimes will go up to, I believe, 30, if you're weakly positive, somewhere in that like 30, 40, 50 range, it's not as much of a slam dunk, but it's a really good marker, and it does correlate with endoscopy findings if you use a cutoff of 100 or more. So weakly positive is a maybe. Strongly positive is almost a slam dunk for this condition. And I'll make a quick note of 100, I believe it's U per ml is the measurement here. So that is antibody number 1, and that presents earlier in the clinical progression of this disease. The other thing that you can have antibodies to is intrinsic factor. Now again, it could be listed as intrinsic factor antibodies or anti-intrinsic factor antibodies. It's going to be the same thing. Intrinsic factor is also made by the parietal cells. Hold on, let me write this out. Intrinsic factor is also made by the parietal cells in the stomach, and it is needed to absorb and digest your vitamin B12 later on in the ileum. Now, this is the one that's a little bit delayed. So first you start attacking the parietal cells just in general, and you get that antibody typically. And then after the disease has progressed quite a bit, you can get this second antibody, which is present in I think it's 50 to 70% of people with this AAG condition. But the thing about this one is, if this is present, you now have a slam dunk. If it's there, this is virtually 100% specific. You know for sure you have this condition. Now again, I'm going to mention, that does not mean that you get out of the scope and you don't pursue this with your GI doctor, because again, there is a risk of certain gastric cancers that you need to be aware of and you need to monitor for. But if you took this to a GI doctor, I think they would have a pretty good understanding that you have the condition and it's not a matter of confirming its presence anymore. I'll make a quick note. Let's see, this is number 2. So those are the 2 antibodies that you're looking for. Now, a couple of things to know about autoimmunity, and this goes back to a video that I posted on this channel about 2 weeks ago. The first thing that happens in an autoimmune condition is that you get antibodies that are produced against self-tissue, in this case, the parietal cells or intrinsic factor. But on day 1 of that autoimmune process, you still have 99.999999999% of a perfectly functioning, healthy stomach. So you're not going to get endoscopic findings and you're not going to get overt nutrient deficiencies on day 1 of this condition. So there's this weird initial phase with autoimmunity, right? Phase 1, where you have the antibodies, but you don't have the signs and symptoms and you don't have the overt clinical presentation to reach the diagnosis yet. Now, historically, people have looked at this condition and they've said, oh, the antibodies are not accurate. We're not going to use that as a diagnostic marker, or we need to confirm it with the endoscopy because the antibodies could be wrong. But now research studies are finally starting to acknowledge the 3 phases of autoimmune disease that I talked about in that video. And they're starting to realize that they can call this where you have the antibodies, but you don't have overt stomach damage yet. They're starting to call that potential AAG. And when they track these people who have antibodies, but they don't have endoscopic findings yet, they do find that about 50% of those subjects develop the clinical condition with endoscopic findings if they follow them for a period of about 6 years. So that idea that I presented 2 videos ago of phase 1, just having the antibodies, but that's the beginning, and then you've got to watch it or try to stop it so that it doesn't progress, I think really holds true for this condition. So if you are a person who, let's say you do the blood work and you have one of these antibodies, and then you go to your GI doctor and they scope you and they say, nope, you don't have the condition. Now you have this working understanding that you can know that you could be labeled as having potential AAG or early stage AAG, and you should do everything in your power to slow or halt the progression of the condition. And if your symptoms get worse, you should go get another scope in a couple of years, because there is some likelihood that this could develop if you have the antibodies present, right? So that's kind of the framework that I set forth a few videos ago. Now, the other thing to know about measuring antibodies in blood, and this is going to be the same for any autoimmune disease. It doesn't matter if we're talking about Hashimoto's, celiac disease, or AAG, but there is a possibility to be seronegative, which means that there are no antibodies measurable in your serum. For this particular condition, this is more common in people of Western European descent, and across the board for all autoimmune diseases, seronegative autoimmunity is more common the older you get. And that's because the immune system starts to lose some function, goes through something called immune senescence or immune system aging. And the older you get, the less of a robust immune and antibody response you're going to produce. Therefore, old folks tend to have a higher incidence of seronegative autoimmune disease as opposed to young whippersnappers. So if you're in your 20s, 30s, or 40s, you could probably look at these with some accuracy. If you are in your 70s or 80s, take it with a bit of a grain of salt because there's going to be a higher likelihood that you could have a seronegative version of this condition, and you might actually need to do the other diagnostics and the endoscopy to get an answer. Now, the other thing to know about the autoimmune marker side of it is that a lot of papers now are saying that once you get the diagnosis of AAG, you need to automatically test those patients for autoimmune thyroiditis, so Hashimoto's and Graves'. And that's because, as we discussed in the other video, autoimmune thyroiditis is very, very, very common in this group of people, at about 1/3 of people having autoimmune thyroiditis. So if you get this diagnosis, you should automatically be reflexively checking your thyroid antibodies just to try to rule that in or rule that out because it is so strongly correlated with this AAG condition. Now, all that being said, so I think that pretty much covers the autoimmune piece of it, yeah? Let's get into the nutrient markers. Now, first things first, I'm going to pause and we're not going to talk about blood work quite yet. So I'm going to actually put this one in parentheses because it's not technically a blood test. I would be irresponsible if I did not remind you to please track your nutritional intake first before jumping into something like this. Don't be the person who comes to me and says, I don't know why my iron is so low, but then we look at your chronometer and it turns out you don't eat anything with iron. Similarly, don't come in scratching your head and saying, gosh golly gee, I have B12 deficiency. This is crazy, when it turns out you just don't eat anything with B12. Right? So I'm going to put in parentheses, because it's not a blood test, use chronometer, or maybe something similar. I don't know, MyFitnessPal, there's probably a million of them, but I like chronometer. Do at least a couple days, if not a week, of nutrient tracking and get a sense for, hey, do I eat iron? Do I eat B12? Do I have reason to have a deficiency that's related to nutrient intake as opposed to a disease? Once you get through that initial hurdle, then I would welcome you to explore these other options, including AAG. So for nutrient markers, number one, as I mentioned in that other video, iron is actually the first nutrient that gets impaired in AAG. And the iron deficiency can precede B12 deficiency and what's called macroscopic anemia by several years. So the first thing to have on your radar in the earlier stages of this disease are iron deficiency markers. So that would include things like a CBC, complete blood count. You can look at an iron panel. I'm going to include with TIBC. I think that's a very useful marker. And you can look at ferritin. I hope I spelled that right. So you could look at all of these. So in the early stages of iron deficiency, you could have a decreased ferritin and decreased iron and iron saturation on an iron panel, and your TIBC would start to go up in iron deficiency. When you get to the stage of iron deficiency that's so bad that now you have anemia, that is where the CBC will be impacted, and you'll start to see a drop in red blood cells, hemoglobin, hematocrit, and some of those other numbers you see on the CBC. Now, the type of anemia you see with iron deficiency is different from the type of anemia you see with B12 deficiency. And what's weird is that they look opposite, right? So in iron deficiency, the red blood cells are going to look pale and small. In B12 deficiency, they're going to be huge and they're going to be darker colored. So we have these opposing forces. And later in the disease progression, when you have somebody with both iron deficiency and B12 deficiency, the pattern recognition on the CBC gets a lot more difficult because those two things kind of cancel each other out somewhat. And you can get what's called a normochromic anemia, where red blood cells, hemoglobin, and hematocrit are low, but everything else kind of looks normal. So I wanted to mention that because it can be a complicating factor in the interpretation of this test. But nonetheless, you can look at these first. And honestly, I think that this is a reasonable thing for everybody to do once a year. Iron deficiency is so common, you might as well just slap that on when you get your cholesterol tested with your PCP every year. Number two, you can look at markers of B12 deficiency But as I mentioned in the case of intrinsic factor and just a moment ago, the iron deficiency usually precedes the B12 deficiency by several years. And likewise, the antiparietal antibodies usually precede intrinsic factor antibodies by several years. And the main manifestation of the B12 deficiency that's talked about in research, which is this type of anemia, is what's called, it is considered a late stage of this condition, and it's only present in 15 to 25% of people with AAG. So that being said, B12, you could look at serum or just run-of-the-mill blood B12 level. That's something. You could look at a marker called methylmalonic acid, MMA. I like to measure it in urine, mostly just so that I don't steal extra blood from somebody who may or may not have anemia, right? And you can measure it in urine through LabCorp or Quest. It's easy to do. You could also look at a marker called homocysteine. That'll have to do. Homocysteine tends to go up in B12 deficiency, but there are other nutrient deficiencies and other nutritionally related things that can cause an increase in homocysteine. So if you saw that alone, I don't know if it would be a slam dunk for this, but I'd be curious if you saw the pattern emerging of, oh, my serum B12 is a little on the lower end, methylmalonic acid is a little on the higher end, and my homocysteine is kind of creeping up too, then you could put 2 and 2 together. And then last but not least, as I mentioned, if the B12 deficiency is there for a long enough period of time and it's bad enough, it can start making you anemic and it will start affecting red blood cells. And that's where you're going to see that pattern on the CBC. Again, big cells, darker colored, this macroscopic anemia, as opposed to iron deficiency where the cells are going to be pale and small. So that would be reflected in the markers of MCV, MCHC, and MCH, which it's the next chunk on the CBC. So the first chunk is usually white blood cells, red blood cells, hemoglobin, hematocrit. And then the next chunk under that is what I'm talking about. MCH, MCHC, and MCV, sorry. Those 3 will tend to go up in stages of B12 deficiency anemia, and they will tend to go down in cases of iron deficiency anemia. And like I said, if you have both, they can kind of cancel each other out. So just keep that in mind that the CBC might be limitedly useful at the later stages of this condition. But nonetheless, we have markers of autoimmunity and a couple of notes about seronegative autoimmunity being a thing and needing to rule out autoimmune thyroiditis. We've got the nutrient markers. Now let's get into the markers of corpus atrophy, or the actual atrophy of the stomach itself. It's worth pausing before this section and just mentioning that these tests are not going to be as routinely available, say from your primary care doctor, as all of these would be. Any of these your primary care or your functional medicine doc could easily order for you, no problem. These 2 markers are going to be a little bit more obscure and uncommon, and you might genuinely need to go to a GI doctor in order to run them. The other thing is I was able to find a listing on Quest and LabCorp's website for the first of these markers, but not the second, which makes me think that it's going to need to be ordered through a specialty lab. Now, sometimes you can put in a request through LabCorp or Quest and have them mail the sample to, Cleveland Clinic or Mayo Clinic and get a special sample run. But this is why I'm suspicious that I think the second one in particular might need to be run through a GI doctor's office if you wanted to pursue that at this stage. So that being said, I'm going to tell you about 2 markers that are markers of corpus atrophy in the stomach and can kind of tell more of the clinical picture alongside these other markers. So the first one is gastrin. And I was able to find an assay for this from both LabCorp and Quest. Gastrin is the gut hormone that normally tells the parietal cells to make stomach acid. So in states of low stomach acid, there's a feedback loop where your stomach is sensing that there's not enough acid, so it's cranking up the gastrin. And then there's still not enough acid, so it cranks it up more. But there's still not enough acid, so it cranks it up more. So in states of low stomach acid, you can get elevated levels of gastrin. However, what's important to note is that this marker by itself is not going to tell you exactly what's going on, because there are other conditions that can cause low stomach acid, namely proton pump inhibitor use, which can increase serum gastrin by about 5-fold, and H. pylori, which is known to cause low stomach acid as well. So the recommendation before you get this test is that you discontinue any PPI or acid suppressing medications. So think PPI, H2 blocker, Tums, anything that's neutralizing your stomach acid, you would want to discontinue at least a few weeks before getting this tested. And you would want to rule out H. pylori before you even pursue this. As a note, by the way, this is really interesting, but H. pylori might be tangled up in this for a lot of people, and it's hypothesized to be one of the root causes of this autoimmune condition. And one thing that's been noted is that anti-parietal cell antibodies decrease significantly after eradication of H. pylori in H. pylori positive patients. So it's kind of this like, which came first, the chicken or the egg? Like, did you have this autoimmune condition all on its own? Or was the autoimmune condition started because of the damage done by H. pylori? And it could be confusing to figure out which of the conditions you have. So it is recommended in almost all of the papers that I've read that you identify and treat and eradicate H. pylori first before you bother running some of these tests, because otherwise you might get a falsely high number here and a falsely high number here. But anyway, as a side note, so gastrin is going to go up in cases of hypoachlorhydria. Again, there are many reasons for low stomach acid, but the two most common that I thought I would mention are H. pylori and PPI use. Now, the other thing is there's a test that is mentioned in more recent research. I'm talking the last like couple of years, and it is pepsinogen 1 and 2. And the idea with this is that pepsinogen 1 will go down in cases of autoimmune atrophic gastritis, but number 2 will not. So you can look at these two markers and you can look at the ratio between them, and that can start to hint where the low stomach acid is coming from, and if it's coming from the corpus of the stomach, which is where this condition is going to manifest. So this is the one, though, that I said I have yet to find it available directly from LabCorp or Quest. So I think it would have to be run through like a GI doctor at a hospital who has access to hospital labs, or it would have to be a specialty lab that's mailed out to like Cleveland Clinic or Mayo Clinic, or maybe it's just not widely commercially available yet, and maybe this is not an option at the time of the recording of this video. But this is, in theory, the three-step process. So we have the autoimmune markers, the two antibodies. We have the nutritional markers from the nutrient deficiencies caused by the hypoachlorhydria. And we have these two markers of gastric corpal atrophy that may or may not be available where you are at the time of this recording. And what's interesting is the utility of doing this testing goes way up if you get a combination of markers as opposed to just doing one. Because like I said, none of these are perfectly accurate in and of themselves. The whole thing with lab testing that I try to teach people is that it's usually not about one single marker. It's about a pattern that you can recognize from many different laboratory markers, especially if you follow them in one patient across time. So one incidence of B12 deficiency won't tip you off to this, but B12 deficiency and iron deficiency and intrinsic factor antibodies and parietal cell antibodies and elevated gastrin sure as heck would. And this is something that's talked about in research, this idea of combining these types of diagnostics to get a better, more robust, more accurate clinical picture. So for example, one of the studies that I read said the diagnostic performance of these biomarkers increases when used in combination, in particular using the well-known markers of gastric autoimmunity like parietal cell antibodies with the lesser-known biomarkers of gastric autoimmunity and gastric atrophy. The first frequently decreases over time. So this is like, so as more of the self-tissue is destroyed in an autoimmune condition, there is less tissue for the immune system to destroy, right? It's like if you were cutting down trees in the forest and you started on day one with 100 trees, and then time goes on and you're chopping down a few trees every single day. Towards the end of that project, you're only going to have like 2 or 3 trees. So there's not going to be a lot of debris and shrapnel and sawdust flying, right? So the amount of tissue debris and autoimmune marker goes down in more progressed forms of the disease. Versus these markers tend to go up the longer the disease duration persists. So you get this combination where like these might be more accurate and more useful in young people or in people who have less progressed disease, whereas these markers might be a lot more useful in people who are older or people who are hypothesized to have more advanced disease states. And I'm going to include a little visual that one of the articles included where they show kind of how one increases and one decreases. I don't know. You can see for yourself because I'll put it on the screen. Anyhow, the other thing that I thought was really neat is that one study said that the combination of these two antibodies, anti-H. pylori antibodies, and the measurement of serum gastrin is known as a serological gastric biopsy. And if you get positive results with all of these, and you could rule out H. pylori, it is recognized as being really, really useful diagnostically, and it highly correlates with histological findings. Meaning, if you get positive antibodies and positive gastrin and negative H. pylori, you have a near slam dunk when they go in there and do the endoscopy and send that out for histological examination. You can almost be guaranteed that you have an accurate diagnosis at that point. But again, I want to urge, you do need to work with a GI doctor on this and get scoped at least occasionally because there is an increased risk of gastric cancers from this particular type of autoimmunity. So you don't want to do the armchair diagnostic thing here. You actually do want to work with your GI if for no other reason than the scopes. You don't have to accept their treatment. You don't have to work with them from that angle, but at least use them for their diagnostic ability and their ability to keep you safe and detect gastric cancers sooner rather than later. This is the point in the video where I'm going to tell you about some of the other free resources I have here on this channel and on the IBS Freedom podcast. And then I'm going to tell you just a teeny bit about FODMAP Freedom in 90 days. So first off, a lot of these topics have been covered in some way, shape, or form here on this channel. So for example, if you do a search for autoimmune, you're going to find videos about the 3 phases every autoimmune disease goes through, the only root cause for autoimmunity, all of them. Doesn't matter what the diagnosis is. They only ever have so many root causes. And we can talk about in another video whether or not it's possible to cure an autoimmune disease rather than put it in remission. So search for the word autoimmune and you'll pop up a whole bunch of goodies on this channel pertaining to that topic. Also, the topic of low stomach acid I have talked about ad nauseum almost on this channel. We've covered topics including toning your vagus nerve for better stomach acid production, symptoms of low stomach acid, how to do a betaine HCl challenge at home to determine if you would benefit from that supplement and if you have low stomach acid. So likewise, if you search on this channel for low stomach acid or hypoachlorhydria, you should be able to pop up videos there. And I believe, I could be wrong, but I believe I have discussed some of this on this channel as well. If I haven't, then head on over to the IBS Freedom podcast channel, which is a separate channel here on YouTube, or available on audio-only podcasting apps. But we have talked a lot about B vitamin deficiency, iron deficiency, anemia, blood flow, blood sugar, a lot of other topics that could be very pertinent for this group of people. I have yet to discuss these markers here on this channel or on that podcast, but that's in part because these are very, very new, especially the pepsinogen 1 and 2 testing, which only is making an appearance in articles in the last handful of years, from what I can tell. But all of that, like I said, I have a lot of free resources that you can continue learning about, and you can learn about how to manage autoimmunity, how to manage the nutritional side of things. But like I said, I wanted to also tell you about FODMAP Freedom because we're going to be enrolling again for FODMAP Freedom come January 2025, and that's really right around the corner. The holidays are going to fly right by our heads, lickety-split, and then we're going to be left with New Year's resolutions and seasonal affective disorder and whatever else we get in January. And it's going to hit you like, ooh, this is the year I want to get rid of bloating, indigestion, SIBO, constipation, whatever. And if that is the case, I would love to spend my new year with you, and I would love to coach you and help you understand what in this sea of information on the internet is actually relevant and pertinent to you. What should you focus your time, attention, and money on? And what could you just kind of table because it's not as relevant for you? And I would help you get through hiccups and little setbacks if you try a betaine HCl challenge, for example, and you never get that warming sensation that we talk about. What does that mean? Like, do you have super duper ultra low stomach acid and are you totally doomed? Or is there another explanation? If you do a betaine HCl challenge and you can't do it because you immediately get burning or reflux or a warming sensation, well, what do you do now? Are there alternatives? This is the sort of stuff that we talk about every week in the 4+ live Q&As that we do with our FODMAP Freedom students. It's me and a nutritionist guiding you along the way. And I think that it's the support and the coaching that really makes it effective. If FODMAP Freedom was just about chucking a bunch of videos at you and teaching you stuff, then you would have gotten better watching videos like this on YouTube. I really think that it's the coaching and the support and the interactions that we have that make the biggest difference for our students. But if you don't believe me, come check it out. There's a link down in the description box so that you can join the wait list. And that will not only let you skip the line so that you can basically snag your spot before anybody else, and that's helpful because we actually have had to cap enrollment in the past, but also you're going to get a bonus gift if you join us during early enrollment week. So check out that link. There's no commitment. You're just giving me your email so that I can send you an email when we open up in January. But I would love to spend my new year with you and make sure that 2025 is the last year you ever have to hear the words low stomach acid, SIBO, bloating, or constipation. So come join us. We have garlic. It's a fun time. Now, I will see you in the next video when we talk about the management and treatment of autoimmune atrophic gastritis.